So in this section, we'll look at puberty and menopause. Puberty marks the beginning of a woman's reproductive life, and menopause marks the end. So although puberty generally begins at 8 to 10 years of age for most girls in the US, it occurs significantly later in many countries. However, there's a study in 1997 of more than 17,000 girls in the United States, and it showed some really crazy results. That about 3% of black girls and 1% of white girls were beginning puberty as early as age 3, and that 27% and 7% respectively were beginning by age 7. Now, there are many theories on the reasons behind this. Naturally, there's an improved state of nutrition. However, there's a lot of other things to consider, like all the environmental estrogens that we consume from the plastics that are involved in our lives. So, puberty's triggered by rising levels of GnRH, just as it is in males. And this rising GnRH level stimulates the anterior lobe of the pituitary to produce follicle-stimulating hormone and luteinizing hormone. FSH is going to stimulate developing ovarian follicles, and they'll begin to secrete estrogen, progesterone, inhibin, and a small amount of androgens. Estrogens are feminizing hormones, but they have widespread effects throughout the body. Estradiol is the most abundant variety of estrogen. Estriol and estrone are another two examples. Thelarch is the onset of breast development. This is the earliest noticeable sign of puberty. We'll see initial duct and lobule formation. Estrogen, progesterone, and prolactin are responsible for this. The completion of the duct and lobule formation, however, is under the influence of glucocorticoids and growth hormone. Breast enlargement will be completed by the age of about 20, with deposition of adipose and fibrous tissue. The next sign of puberty is pubarch, which is the presence of pubic and axillary hair, sebaceous glands, and axillary glands. Androgens from the ovaries and the adrenal cortex stimulate pubarch and an increase in libido. Menarche marks the first menstrual period, and it requires at least 17% body fat in a teenager to begin. And in order to maintain menstrual periods in adulthood, 22% body fat is required. Anytime we drop below these body fat percentages, we'll often see cessation of menstrual periods. And in a teen that has less than 17% body fat, we'll see delayed onset of menstrual period. Now, it used to be that the average age for onset was about 16 and a half years old. Now it's about 12. And it's proposed that this is due to improved nutrition, which of course would lead to higher percentages of body fat earlier. You might recall from a previous chapter that leptin, which is a measure of fat content, stimulates gonadotropin secretion. If body fat drops low, gonadotropin secretion declines, and FSH and LH decline, and the cycle might cease. The first few menstrual cycles are anovulatory. Girls begin ovulating regularly about a year after they begin their menstrual periods. So now let's take a look at the hormones that control puberty in females. Estradiol, we said, was the predominant estrogen. This stimulates vaginal metaplasia, that transition from simple cuboidal to stratified squamous epithelial cells. It stimulates growth of the ovaries and the secondary sex organs. It stimulates growth hormone secretion, which aids to increase the height and widening of the pelvis. It's responsible for the feminine physique because it stimulates fat deposition, and it makes girls' skin a little bit thicker. but not quite as thick as males of a corresponding age. It's still much thinner, softer, and warmer. Progesterone is another very important hormone. It primarily acts on the uterus, preparing it for possible pregnancy in the second half of the menstrual cycle. Estrogens and progesterones both suppress FSH and LH secretion through negative feedback loops. And when we examine the female cycles, we'll take a look into this a little further. Inhibin is going to be involved in suppressing FSH secretion only, which is exactly what we see in the male system. Hormone secretion in females is distinctly cyclic, and the hormones are secreted in a very orchestrated sequence. So menopause, the end of a woman's reproductive life. So climacteric, as in males, was this midlife change in hormone secretion. In females, it's accompanied by menopause, which is the cessation of menstruation, which is why we can't use the word male menopause, because it simply doesn't make sense. So a female is born with about 2 million eggs. And climacteric, this hormone change, begins when there are only about 1,000 follicles left. Follicles are much less responsive to the gonadotropins. We see less estrogen and progesterone secretion, which causes atrophy of the uterus, vagina, and breast. We also see thinner, less distensible and drier walls on the vagina because of the lack of hormones, which makes intercourse more uncomfortable. The skin becomes much thinner. Cholesterol levels rise, which increases the risk of cardiovascular disease. Without estrogen, bone mass declines, producing an increased risk of osteoporosis. Blood vessels constrict and dilate in response to shifting hormone balances, and so this is what contributes to the hot flashes, which spread a sense of internal heat from the abdomen to the thorax and up to the neck and face. Now, some women choose hormone replacement therapy, which is low doses of estrogen and progesterone that relieves some of these symptoms. It's very similar to oral contraceptives, the same sort of hormone doses, and so thus it mimics what we would experience in a normal cycle. There's a lot of controversy around hormone replacement therapy because there are risks as well as benefits. So that brings us to the conclusion of our section on puberty and menopause. Next, we'll move on to oogenesis and the sexual cycle.